This recording will go over pulmonary hypertension and cyanosis. Pulmonary hypertension is elevated blood pressure in the blood vessels of the lungs. Initially, infants with significant left to right shunting defect have reversible pulmonary vasoconstriction and increased pulmonary blood flow that causes elevated pulmonary artery pressure. Pulmonary hypertension occurs over time when vascular changes eventually lead to vessel wall thickening, severe irreversible vasoconstriction, and vascular obstruction. This severe condition leads to a reversal of the cardiac shunting, becoming a right to left shunting with less blood pumped into the lungs, so that a previously acyanotic child becomes cyanotic as oxygen poor blood gets pumped to the body. Repair of lesions with large left to right shunts is generally recommended in the first 3 to 6 months of life. Children with large left to right shunting lesions, particularly at the ventricular level, have high pulmonary artery pressures but low pulmonary vascular resistance. Initially, heart failure develops. Management is directed toward treating the symptoms of heart failure, including treatment with digitalis, calcium channel blockers, diuretics, warfarin, and supplemental oxygen. Additionally, the family is advised to have the child avoid strenuous exercise and high altitudes. Vasodilators can be helpful if the child demonstrates adequate response when these meds are given during cardiac catheterization. With early surgical intervention, children with reversible pulmonary hypertension can have a return of normal pulmonary pressures post-op. Early intervention is important because the increasing pulmonary vascular resistance caused by pulmonary vascular changes puts the child or the children at higher risk for surgical morbidity and mortality and for the development of irreversible pulmonary hypertension. Cyanotic cardiac lesions produce cyanosis when desaturated blood from the venous system enters the arterial system without passing through the lungs, commonly through an abnormal opening that enables shunting of desaturated blood. Cyanosis, a bluish discoloration of the skin, nail beds, and mucous membranes, appears when tissues are deprived of adequate amounts of oxygen. Cyanosis becomes visible when hemoglobin that is not bound to oxygen reaches a level of approximately 5 grams per deciliter blood, and the measured oxygen sat drops below 85%. The degree of cyanosis varies. Some children will appear pale and mildly cyanotic, while others will appear quite dusky. In anemic infants or children, desaturation will be higher before cyanosis is apparent. Conversely, with significant polycythemia or increased red blood cells, children will appear cyanotic with less desaturation. Cyanosis can occur when blood flow to the lungs is decreased, such as in severe pulmonary artery stenosis, pulmonary atresia, tetralogy of Fallot, or tricuspid atresia, or desaturated blood is pumped to the body, such as with trunctus arteriosus and hypoplasic left heart syndrome. Cyanosis intensifies with crying in children with these defects and is not alleviated by the administration of 100% oxygen. The clinical consequences of cyanosis include polycythemia, anemia, clotting abnormalities, hypercyanotic episodes, central nervous system injury caused by absence or embolic events, pulmonary hypertension, and endocarditis. Polycythemia is a compensatory response of the body to chronic hypoxia. The body attempts to improve tissue oxygenation by increasing the oxygen carrying capacity of the blood, in other words, by producing additional red blood cells. Accelerated red blood cell production increases the viscosity of the blood and crowds the vascular space, so there is less room for plasma and clotting factors. Children who are polycythemic are at greater risk for bruising and prolonged bleeding because of decreased specific clotting factors. Increased blood viscosity makes the peripheral circulation sluggish and places the child at risk for CNS injury from a brain abscess or cerebrovascular accident. Depletion of iron stores can also result, and anemia can develop if iron is not available to participate in hemoglobin formation. Dehydration can occur in cyanotic heart disease rapidly. Hyperthermia, poor oral intake, vomiting, and diarrhea can cause acute dehydration. Dehydration can be life-threatening for the child with a cyanotic heart disease because the fluid loss can contribute to the relative viscosity of the blood. A serious, clinically significant, and dramatic event seen in children with cyanotic heart disease is the hypercyanotic episodes. These events are often called TET spells because they frequently occur in children with unrepaired tetralogy of Fallot. These episodes last a few minutes to a few hours and include rapid and deep respirations, irritability and crying, peripheral vasodilation, increased systemic venous return, increasing cyanosis that can be very severe, and a decrease in the systolic murmur reflecting decreased pulmonary blood flow. Hypercyanotic episodes are seen most frequently in the first 2 years of life and seem to occur mainly in the morning. Often the episode is preceded by crying, feeding, or defecation. The infant becomes agitated and may eventually lose consciousness. Although usually self-limiting, the spells can progress to a vicious cycle that can be fatal if not recognized and treated. Frequent or prolonged episodes can lead to diminished cerebral oxygenation and ischemic brain injury. Treatment of the episode includes calming the infant, placing the infant in a knee chest position to increase systemic vascular resistance and force blood to the pulmonary system, and administering oxygen, which causes pulmonary vasodilation. Morphine sulfate is administered to suppress the respiratory center and decrease the hyperpnea, which contributes to vasodilation. Potent medications that cause vasoconstriction may be needed to increase systemic vascular resistance, decrease the degree of right to left shunting, and force blood into the pulmonary system. Please review the purple nursing care box of the child with cyanosis on your own.